Hello, and thank you for being part of this taped interview, part of Multiple Sclerosis News Today's official coverage of ECTRIMS 2017. To begin, the MS-SPI trial, or SPI trial, and its open-label extension studies have demonstrated that patients with non-active progressive MS benefit from treatment with MD 1003 for, and I believe the time frame was up to 36 months. Dr. Ayman Touba presented data on improvements in both disability scores, EDSS, and walking ability among treated patients. Could you please describe how large the clinical impact of these improvements were? And I was wondering if there was a notable difference for patients in terms of disability.
So first of all, the trial had a very ambitious primary endpoint, which was basically the reversion of progression. Although most of the trials are looking at decreased progression, here we were looking at patients who would not simply not progress, but more than that, would improve, would reverse their progression. So that was the first time we used a very ambitious endpoint of this type in the progressive MS population. So the effect is not huge. I mean, it's 13% of the patients who reach this endpoint at the end of the double-blind phase, but compared to 0 in the placebo group, because basically this is something which is not supposed to happen spontaneously in this population. So the primary endpoint was very ambitious, which explained probably the relatively low number of patients who attained the endpoint, although it was statistically significant, which means that the effect is real. The nice thing about the extension phase is that we observe a similar rate of responders over time. So not only the endpoint was reached and was ambitious, but it seemed to be maintained over time, even after 3 years of treatment. The other thing which is very interesting and very important to understand is that the patients who did not improve to that level in the trial still benefited in terms of decreased progression of their disease. In other words, the treatment had the potential not only to reverse progression, but also to stabilize in the patients who were not able to improve. A nice way to demonstrate that was to look at the overall change in the EDSS score, which takes into account the patient who improve, who worsen, who stabilize. And overall, what we observed is a relative stability in the patients who were treated since the beginning. So overall, some patients improved, few worsened, which creates a kind of stabilizing, disease. The ones who were on placebo progressed initially, so more patients worsened than improved. Nobody improved, but some patients worsened, which creates an increase in the slope of progression. And then the patient on placebo were switched to the active, and they stopped to progress. Okay, so that's very interesting. But the thing which is important is that the two curves, even after 3 years of treatment, did not catch up, meaning that the patients who were treated on placebo and who received the treatment 12 months after the others got a higher level of disability and did not recover to the same level, which is a kind of demonstration that the treatment has to be started as soon as possible, because if not, the patient will progress and will not recover. So, in other terms, if you take only the primary endpoint, the effect can be, for certain persons, considered as modest because it's 13%. But you have to imagine that 13% over something which never happens is already important. And on top of that, there is an effect which is the decrease in the disease progression, which is another phase of the treatment effect. So if you combine both, I think that's a very, very promising trial, and the results are overall very consistent and show a maintenance of the effect over time, which is important.
Did you have a particular group, or did you come to a realization of at what stage of progressive disease you had to begin this treatment to have the best effect?
Yes, so we start to have a good sense about that. That's a very good point. In MS, even in progressive MS, there are perhaps two mechanisms that drive the progression. So one is the inflammation. We know that there is ongoing inflammation. And now people tend to speak about active progressive MS when there is ongoing inflammation, either relapses, clinical relapses, or lesions, MRI lesions. But there is another mechanism which drives progression, which is more related to neurodegeneration and perhaps a virtual hypoxia phenomenon. And this one occurs whatever inflammation. So there is a link between the two, but there are probably two mechanisms. So we know that the MD103, the high-dose pharmaceutical biotin, does not act at all on inflammation. There is no expected effect on the first component of the disease, which is inflammation. So in other words, the patients who are progressive and with ongoing relapses or MRI lesions should not be treated or should not be candidates for this approach. The patients who seem the more likely to benefit are the ones who are perhaps in a more advanced stage, who do not have any more inflammation. Those patients where many immunosuppressant drugs have been tested and failed. Obviously, there is still some progression despite the use of other treatments. So these patients, there is a belief that the degeneration, the worsening is driven more by a neurodegenerative process and not anymore by inflammation. And these are the patients who should be, in my opinion, in the future treated by this drug, yes.
Did the analysis show a more marked improvement in those patients being treated with MD103 while using other treatments like famotidine for gait problems or disease-modifying drugs, or even those undergoing physical therapy, in comparison to those who are on high-dose pharmaceutical biotin alone?
I think the size of the trial did not allow to completely address these questions. If you make subgroups, you will end with very small subgroups where it's difficult to say. But this morning we presented data, and there is a poster about subgroup analysis using a forest plot, as we say. So it's a way to evaluate the effect of the drug in different subgroups to see whether there is consistency among subgroups. So we cannot pick up a subgroup and test the statistical significance. Perhaps it's too technical, I'm sorry, but just to see whether overall the different subgroups did respond the same way. And whatever the endpoint that we use, EDSS, TW25, clinical global impression assessed by the physician, or clinical global impression assessed by the patient himself, we have the same tendency, which is very consistent. The patients who were treated were always in the right part of the graph, meaning improvement. Okay, the improvement was seen in this group of patients who had the drug compared to placebo. So any type or any group of patients have better outcome when they are treated by the active arm versus placebo. And this includes the patient with low EDSS versus high EDSS, progressive, primary progressive versus secondary progressive, patients who were on famotidine or not, and also patients who were on DMTs or not, disease-modifying therapies or not. So obviously from the trial, the answer that any subgroup did benefit the same way, or in the same trend, I would say. And that's probably because the mechanism of action is quite different from any other compound. That's the first time we are really addressing the neurodegenerative part and the virtual hypoxia phenomenon, which the other drugs do not really address. So obviously it should work in many cases, which doesn't mean that other treatments are not useful. It is not what I say. What I say is that there does not appear to be a kind of synergy in the rate of response with the MD103.
So you're not looking to at all do an analysis of any concurrent treatment that might match this?
That, but because of the very small number of patients at the end, it's impossible to say. So When we will have more data with a bigger trial, maybe we'll be able to address that more
Might that be
precisely.
part of the current trial, the SPY2, or?
The SPY2 is basically very similar to the old one, but there are many more patients. So the subgroups will be larger, so maybe it will be easier to see big differences.
Were improvements across various types of disabilities, you might have already addressed this to a degree, were improvements across various types of disabilities, perhaps via the clinical global impression scores, or say measures of fatigue? Were improvements seen across those different types of disabilities, or were large improvements seen in particular domains like gait, hand function, or leg function?
Yeah, so that's... So first of all, we included in this trial a quite homogeneous populations of patients who had mainly walking disability. So that was a criteria for the entry into the trial. Patients who had what we call spastic paraparesis, which is the very common presentations of patients with progressive MS who have spasticity, walking difficulties, and that was our population. So we looked at the other dimensions, but it appeared that except walking disability, the other functions were relatively normal in this population. So we had very few patients with real cognitive impairment, as we can depict by the EDSS, for instance. Very low patients who had real disability in the upper arms, etc., etc. So our main population was a population with mainly walking disability. So it's not surprising to see that the main effect is on walking disability, because this was our target population, I would say. That being said, we also have evidence that the clinical global impression did not capture the same dimensions as the EDSS. In other words, there were patients who were improved on the clinical global impression, but not on the EDSS. And reciprocally, a few patients who were improved by EDSS, but not necessarily by the clinical global impression. So we have tried to combine both to see what are the percentage of patients who are improved either on EDSS or on the clinical global impression, and the rate of responders was more close to 35% improvement compared to 13% if we look at EDSS TW25 alone. So that being said, we believe that if we used a more, a composite way of assessing the patient, who will have pick up other dimensions that improve, that we would not be able to pick up just by the primary endpoint. So that's what we think.
Thank you. A presentation at ECTRIMS also showed that a portion of patients do not respond to treatment, which I think someone addressed. Is MedDay analyzing data to identify the particular characteristics of those who do respond to treatment and those who do not?
Yes, of course, that's very important. So, so far it depends how you define response. So we define response as a very ambitious endpoint, which was the improvement. But many others, or many other trials, define response as the patient who do not progress. So if we combine both, we have more responders than just the 13%. And obviously the treatment effect is beyond the 13% patients that we were able to improve. There are also patients who do not progress, or patients who improve with a CGI, for instance, clinical global impression, but who do not pass the primary endpoint, which is based on EDSS. So it depends on how you assess the patient. This is what I want to say. So now there are also patients who still continue to progress during the trial and who obviously do not benefit at all from the treatments, or do not seem to benefit from what we can measure. It's very difficult to say today to see what are these patients. My belief is that perhaps in this population there are patients who still have inflammatory activity that should be perhaps best candidates to other drugs. So that's one. Patients who are still active, and we know that we cannot act on this inflammation-driven progression. Second thing is that we identified as well that patients who were quite stable for a long time, who do not really progress, who have more fluctuations in their status, but who are not really totally progressors are less likely to respond in terms of improvement. We see a better effect in patients who are not active and who have ongoing progression. So that's an interesting thing, but we think that at the end, the real population would be the patients who are not active with ongoing progression despite anything else. That's
one of the findings in the MS-BI trial of MD-103 in progressive MS was reduced brain volume in the year following treatment initiation. This has been interpreted as a result of decreased water volume potentially caused by an increase in brain energy production. Have similar effects been observed in other studies of high-dose biotin, including others that MedDay has conducted? And is it supported by research data showing the increase in energy consumption, reducing the water content in brain tissue?
Yes, that's still speculative. So what we have observed in the trial is that initially, when patients were treated with biotin, so during the first 12 months, there was a decrease in brain volume, which was significantly higher in the active arm compared to the placebo. And then when the placebo was switched to the active, although they did not really atrophy during the first 12 months, then we see a decrease in brain volume. Okay, so there is an initial and very rapid, in the first 12 months, quite significant decrease in the brain volume, which seems to stabilize after that. So it's not probably brain atrophy, because brain atrophy is more a long-term process. And interestingly, this decrease in brain volume accompanies or is associated with the higher clinical benefit, because we know that most of the clinical benefit is observed in the first 12 months of the treatment. So these are the observations. Now we need to understand how it works. So we think, and we have speculated, that because it's a rapid effect and not a long-term effect, and because also it is associated with a clinical benefit, it should not be a real brain atrophy. Brain atrophy is supposed to be associated with clinical worsening, and usually it is a long process that occurs over 2-3 years, but not very rapidly when you start a drug. So that's one. So we think it's more related to brain water content, because that would explain a rapid shrinking in the brain volume, so what we call a pseudoatrophy phenomenon, which is associated with a decreased edema, if you want. And now, that being said, there is a lot of literature, okay, which tells us that when you have a hypoxic phenomenon, like in stroke or like in any situation where you have a hypoxia of the brain, this is associated in a brain swelling, okay, because the axon has little energy to repump the potassium, and the potassium goes into the astrocytes. The astrocytes swell, and this gives an edema, what we call the hypoxic edema. And because in MS, especially in progressive MS, there is some evidence that there is a chronic but subtle hypoxia phenomenon, we think that there may be astrocyte swelling. It has been observed in different instances that creates a kind of little edema. So now when we start the biotin, we are supposed to decrease this hypoxia, because the main target of biotin is to increase the energy, and that in turns is supposed to decrease slightly the volume of the astrocytes. The potassium is repumped into the axon, and that would create this shrinking of the brain that is paradoxically, in our opinion, beneficial. So that's very paradoxical, a little bit provocative, we know that, but that's how we can explain that, yes.
In the new, this BI2, is there any way the trial's been designed, or is there measures being taken to look for this phenomenon, or has findings in any way influenced the outcomes that were set in this trial?
So the SPI2 is quite similar. We will have many more patients, many more MRIs, more frequent. Because of this pseudoatrophy phenomenon, we have decided to include MRIs very early on in the trial to depict the early effects, so we will have MRIs at 6 months, so very early to see whether it's an early onset phenomenon or whether we have to wait for 12 months or longer. But because all the patients in the trial will have the same way to assess atrophy at more regular times, I think we will have more answers about that.
You are recruiting, MedDay is recruiting patients now to this global trial, and it's intended to support or potentially intended to support the approval of MD-103 in the US and probably Europe, possibly elsewhere. May I ask how enrollment is going? This is a hard group. How is enrollment going for this global trial, the SPY2 trial?
It's going well. So as expected, we will see. But
it's a large.
It's a very large trial, so there are 90 different centers which are involved. So we are not expect to recruit all the patients in 6 months, but no, we hope so far so good. We are really in the right curve of recruitment.
According to the trial document, the primary outcome analysis is due in September of next year. And I remember when we spoke earlier, you had mentioned that interim data isn't something you really release because this high-dose biotin takes time to show effect. But it's been almost a year since it technically began. Are you beginning to see promising results in early
We are not
treated
looking at the data before the double-blind phase will end. So it's double-blind anyway, so I cannot communicate on that. I don't know.
Understood. But MedDay has an early access program set up in France,
Yes.
particularly. And when we spoke back in May, you had mentioned there were more than 5,000 patients in this program. And you mentioned that you may discuss data from this early access program at ECTRIMS. Can you highlight some of this data for us and talk a bit about what this role this data might have in supporting further development of MD-1003?
So we have presented this data as a poster, and it was also presented this morning during our sponsored symposium. So we collected safety and efficacy data on 6,500 patients who have been entered in this program. First of all, this gives us a huge, it's a kind of registry, so it's real-life data where we collect mostly the safety in these patients, but also some efficacy measures, very simple ones, like the clinical global impression, like the maximum walking distance, and also the EDSS. The most valuable, the highest value, or the higher value of this type of registry base is the safety. So far, it helped a lot to collect many more safety data regarding serious and normal adverse events. So it helps a lot to know better what are the risks associated with this treatment, with this drug, because remember it's a very, very high dose of biotin, so it may be associated with some risk. And what we are presenting is that overall the safety is very much reassuring, with no new safety signal that would not have been identified during the placebo-controlled phase. So that's one, and that's probably the most important message. Concerning the efficacy, I think that's very interesting because we get very, very similar results as the MS-SPY trial showed. In terms of mean EDSS change, we have almost the same values in the trial, in the active arm of the trial, and in the ATU, the early access program. Also, the walking distance is improving with time as a mean, which is not expected because normally patients with progressive MS tend to have a decrease in the walking distance over time. Here we see a progressive improvement up to 100% change after 1 year, after more than 1 year of treatment, which is very unexpected, of course. And when we look at the clinical global impression of change, we also see that most of the patients, very majority, like 94%, are coded as either improved or stable, and a very significant of them, proportion of them are coded as improved. I think it's 37% after 1 year of treatment. So again, that's very much in line with the results of the MS-SPI trial. And I don't want to overestimate these results because there are pitfalls. There are a lot of patients who are not entered, who are missing data, or who are withdrawn from the trial that we do not control. It's real life. But I think they give reassurance about the validity of the MS-SPI study. They replicate in some way the MS-SPI study, and it tells us, okay, the results of the MS-SPI study, which is the real study, are robust. That's for me the most important.
To the best of your knowledge, though, are the people in this ATU program receiving basically the same dose, the same as those in the trials?
Yes.
Yes, exactly.
That is the same drug, which is controlled, which is a high purity, etc., etc. So,
MedDay, as I understand it, is now seeking regulatory approval for MD 103 in Europe.
yes.
Correct? You are in the process of filing.
Yep.
Good luck to you. And that is ahead of the completion of the SPI-2 study, clearly.
Yep.
Are you planning to try for U.S. approval ahead of completion of SPI-2 or upon completion?
No, for the US, we have planned to wait for the SPI-2 results. So it was a specific request from the FDA to have patients treated in the US to get approval, and they wanted to see this trial. We strongly believe that we have enough data collected so far to get an approval in Europe, and for me the early access program data are very much supportive and give very much reassurance about the absence of safety signals. So we are still in discussion. I cannot tell you what will happen. It will be the decision of the CHMP and the European Commission to decide, but I think that this drug deserves approval right now for the patients. Yes, I strongly believe in it.
Is there anything else you would like to add or emphasize? Point to clarify?
No, I think your questions were very comprehensive. Thank you very much.
Thank you
for
very
asking
much
them.
for your time, guys.
Thank you.
Appreciate it.